Good evening.
Good evening.
Hello,
Hello. Good evening. Good evening.
Good evening.
Namaskar, ma'am.
Namaskar.
Okay, now we can start.
Wonderful day. So many things going on.
Namaskar, Archana ma'am.
Hello, Preeti.
Hello. Dr. Bharti ma'am.
भारती मैम, उषा मैम, अर्चना मैम, स्टार्ट करें?
हाँ बिल्कुल बिल्कुल। भारती की फोटो नहीं आई।
आ गई।
Good evening, ma'am. Good evening, Dr. Archana. Good evening, Dr. Richa, Dr. Kanchan, and all president secretaries. Yeah,
good evening, everyone. Myself, Dr. Kanchan Prasad, one of the convener of today's program. Welcome you all for RAC training session. Respectful abortion care is a joint FOXI and WHO initiative with webinars planned across 4 zones of FOXI for dissemination of recent MTP Amendment 2021. First of all, I would like to invite convener for this program, Dr. Bharti Maheshwari ma'am, Professor and Head of Department OBGYN, Muzaffarnagar Medical College. Ma'am is Governing Council Member ICOG, Secretary UPCOG, and President Meruth Options Gynae Society. Ma'am has authored and edited many textbooks in OBGYN and is recipient of various prestigious awards, including Kamini Rao Oration. Ma'am is Chairperson, FOXI MTP Committee 2018 to 2020, and she has done commendable work in this domain. So it is my privilege to invite ma'am for welcome address, and also I request ma'am to kindly welcome our chief guest, none other than Padam Shri Professor Dr. Usha Sharma ma'am. My pranam to ma'am, and guest of honor, our vibrant North Zone Vice President, Dr. Archana Verma ma'am. So I request Bharti ma'am to kindly take the dais. Ma'am.
Thank you. Thank you, dear Dr. Kanchan, and I am really very grateful to help to organize this webinar. And first of all, I welcome you all in this very important and prestigious program that is FOXI WHO Reproductive Abortion Care CME. And I welcome all, especially our chief guest, Professor Padam Shri Dr. Usha Sharma Madam. She has joined from Australia. She has on her holidays, but madam, thank you very much to encourage us and you have joined in this webinar as a chief guest. And besides that, I welcome all our guests, Dr. Archana Verma. She is a FOXI Vice President and she is in charge of MTP committee also currently. Thank you, Dr. Archana Verma, madam, that you joined in this webinar. And Dr. Richa Sharma. She is a MTP committee chairperson nowadays, and she is doing tremendous work in this committee. And I'm so happy and glad that we have done lots of work together in past 3 years with all of you. We have to do lots of things to update our society members in current year. And welcome all FOXI different societies that we have included in this webinar, like Meerut, Muradabad, Jhansi, and Bareilly, and other societies, Ludhiana, and Gurgaon, Noida. So thank you very much for participating in this and joining this. And I welcome all speakers and all chairpersons, those who have joined from different parts of countries, and all chairpersons from different societies. Just without wasting your time, I just want to highlight 2 things, and then I will invite a chief guest. That of course that MTP, it is not only medical issues, it is social as well as it is legal issue. So we are doing lots of efforts all together, all obstetricians, to make the abortion services accessible to every woman, and prevention and avoidance of the unsafe abortion. So in this efforts, or in this, I should say that this direction, that MTP Act amendment, it is a big revolution which has been done in our countries in 2021. And of course, lots of things we have to know and we have to implement in our clinical practice to make ourselves safe, as well as to keep the services safe and to keep our women safe. So Dr. Usha Sharma, Padam Shri Dr. Usha Sharma, Chief Patron of the UP chapter. She is a patron of Merit Ops and Gynae Society. She is a teacher of teachers. She is source of inspiration for all of us, not only academically, but we have learned, we all of us have learned that how to help our colleagues, how to behavior conduct with the patients, as well as lots of things what are not written in the book. Dr. Usha Sharma madam has taught us. So thank you very much, madam, for being with us. And I request Usha Sharma madam to say a few words and bless this event. Madam.
Thank you very much, Bharti, for saying such nice words for me. And I will like to thank all the three conveners, Bharti Maheshwari, Richa, and Kanchan Prasad, for giving me this opportunity to be with you all. We have here today our very dynamic, loving, affectionate North Zone Vice President, Dr. Archana Verma. And the learned speakers, we have Dr. Krishna Kumari, Dr. Shaili Agrawal, Dr. Jamuna Devi, and Dr. M. Uma. And apart from that, we have chairpersons from different societies like Pragati Agarwal from Bareilly, Alka from Jhansi, Kiran Chandana from probably Faridabad. Am I right? Kiran is from Faridabad.
Yes, madam.
And our Priyanka Gar, of course, she is the secretary of our society, Merit Society. It really gives me a great pleasure to be with you all on the occasion of this training, prestigious, I must say, training session, a combined effort of FOXI and WHO regarding the recent amendment of MTP Act 2021. Safe abortion, respectful abortion care, as just now Bharti told quite much about it, and pre and post abortion contraception counseling. We all know that these days it is very, very important to be well versed with these things, because with all the litigations and with all the legal implications, sometimes it is very difficult to do your day-to-day practice without knowing and without having clear awareness of all these things. And I'm sure the deliberation today, we have got such learned speakers who will be telling us about this MTP Act, the recent MTP Act amendments, as well as safe abortion services, and then the pre and post abortion contraceptive counseling. And I wish this program a great success. I'm sure that this will certainly update the knowledge of every one of us who are attending this, which is really very, very important. And just now, as Richa was saying, that medical board has to be notified before we go to the medical board. Otherwise, the same procedure has to be taken that you have to go to the court, which is quite tedious. And I'm sure that these things will be notified very early and we will be very much benefited by this. Thank you very much, Bharti, Richa, and Dr. Kanchan Prasad. And thank you very much all the speakers who have joined today to give us the knowledge of various subjects. And I'm sure that we all will be greatly benefited by this. I wish this program a great success and wish you all a very happy and bright future. Thank you very much once again.
Thank you. Thank you, madam. And now I invite, thank you very much.
I would like to add one thing. All of us know Bharti Maheshwari, and we know that how much work she is doing. She has done tremendous work, and I can say, I always used to tell her that she is a chairperson on wheels. Today she is in North, tomorrow she will be in South, and day after she will be in East. And all of you will agree with me that such a sincere and dedicated candidate should always be supported. And I will be happy to tell you all that she is contesting for the Vice President North Zone, and she will be just following our Archana Verma. And I'm sure that her merit and competence, every one of you know, and request you all to please support her. I only wish that she is unanimous like Archana Verma, but let us see what happens. It is all in the game. And wish you all the best, Bharti, for your Vice Presidentship North Zone. Thank you very much.
Thank you, madam. And in continuation of this, I request all of you that please nominate and support me for incoming years for North Zone Vice President candidates and give me opportunity to continue to be. Thank you very much, madam. And your blessings is really treasure for me. And that is very important and very precious for me. Thank you. So now I invite a next guest, that is none other than our own Dr. Archana Verma madam. We all know that she is a North Zone she is the Vice President of Foxy as well as MTP committee in charge. And I think Dr. Archana Verma, she is Vice President and she has lots of posts and designation, but she is very much close to our heart, and every one of us feel that she is our very close friend. And that is true, that how much she is helping, supporting, encouraging, and so academic and active. And we have seen her work as a vice president, as a public affairs committee chairperson, as well as her society's president, and on lots of designation. So we are so pleased that today we have Dr. Archana Verma with us. So madam, I request you to bless the event and say a few words. Dr. Archana Verma.
Thank you, Dr. Bharti. I think with the God's grace, you have got the bestest person with us today, none other than Padam Shri Dr. Usha Sharma Madam. She always talks positive. She always talks so respectfully, and she always teaches and guides and mentors so many people. So greetings from Foxy, and I'm really very happy to say that like we want our patients to be in the safe hands, to have very good doctors who are giving the bestest care respectfully. So we have the best chairperson. This committee is in the safe hand of Dr. Richa Sharma. She is enriching everybody with her talent and brightness and work, and same the Bharti. Bharti को तो मैं बस जैसे मैडम कह रही थी, I can say one word, मेरा भारत महान तो मेरी भारती भी महान. So today's all the guests and all the friends, those who have joined, and it's really my honor to be here as a guest, though I am a host. And I want to do a lot for all my friends, and this, like our president Foxy says, that Foxy is for all. Definitely it's for all, because we know that's MTP Act, though we all feel very unsafe sometimes, but it is really an umbrella. It protects you from so many issues, and if you do it everything under protocol, you are automatically doing everything for all very nicely and taking care of the PCPNDT Act also. And the other major factor is a safe abortion. Of course, if we are doing in protocol, the patient will be in safe hands, and the safe abortion care and the comprehensive care, we need to remember this comprehensive care is something very, very important. Whenever a patient comes, don't ever be judgmental. Always try to be at her foot instead of just listen to her. And always that is a time when she's mentally upset, her family is upset, because it is a unwanted pregnancy. She will listen to you all, everything. Never ever judge. Just offer her basket of options for pre-counseling also, post-counseling also, and everything will be set. And if we have a goal, we can always put it. So today's all the speakers, Dr. Krishna Kumari is my all-time favorite teacher, and Shaili Singh is again very dynamic person from Uttar Pradesh, and Dr. Kiranmay, and I think Dr. Bharti herself is there, and Dr. Richa. All of you take care, and all my friends present here, all of you take Kanchan and Saroj, Alka, they are all, we are all team, we all work together. You know, though madam says me vice president, I always feel like her only. So thank you very much, madam. Thank you so much.
It is your humbleness, Archana.
Thank you, Dr. Archana. Thank you. So now I invite Dr. Richa to say a few words as a current MTP committee chairperson, then we will move to the session.
Thank you, Dr. Bharti ma'am. A very good evening, everybody. My regards to Padam Shri Usha Sharma ma'am, Dr. Archana Verma madam, presidents and secretaries of various societies, then today's faculty and the participants. Now, respectful abortion care CME is now it is being organized in almost every society, and this is a wonderful initiative of Foxy and WHO. because it is very important to know about the safe abortion. As we all of us are aware that unsafe abortion, it is a third leading cause of maternal mortality in India. So nearly almost 10 women, they die every day, and 1,000 women, they suffer from the serious morbidity because of unsafe abortion. So it is very important to know what is safe abortion. And at the same time, it is very important to know what are the medical legal implications which are associated with MTP Act and the law. And very important to update ourselves. So now I will hand over to Dr. Kanchan without wasting much time. So let us listen to our eminent speakers and update our knowledge. So thank you so much.
Yeah.
And
thank you, Richa. And in the last, we will like to thank and congratulate Dr. Shanta Kumari Madam that she has arranged this very good MTP programs, and whole congratulations to whole Foxy team. Yes.
Yes,
so now
I want to say one word also. We have here Dr. Ajay also, and he is the main person who has just made this RAC training.
Dr. Ajay Bhardwaj, yeah, he's here.
All over India.
Yeah. He has login? No.
Yeah.
Dr. Ajay, you are there?
Yes.
Yes.
Yeah, Dr. Ajay?
But you're very kind to say those few words, Archana. I'm really humbled and honored. Yeah.
Whatever she has said, she is absolutely correct, Ajay.
Oh my God. Okay. No, I'm thoroughly delighted and absolutely pleased to be here. And with folded hands, thank you very much for all the honor and all the love and respect that each one of you have. Pleasure.
Thank you, Dr. Ajay. Thank you. So now, Dr. Kanchan, please proceed for the scientific event.
Yes, ma'am. Thank you so much, Bharti ma'am. And I want to thank Ajay sir also for coordinating all this. And moving on to our first talk, I would like to invite the chairperson, Dr. Pragati Agarwal ma'am. She is secretary, Bareilly OBGYN Society, and she is very dynamic person, and she always says yes. So I request ma'am to kindly introduce the speaker of our first talk.
Thank you, Dr. Kanchan. We know our MTP Act has been amended recently in 2021. What are these amendments? Dr. Krishna Kumari will speak in detail on this topic. Let me first introduce her. She is from Hyderabad. She is Professor Apollo IMSR Hyderabad. I invite Dr. Krishna Kumari to give her talk.
Thank you. Thank you so much, Dr. Pragati. At the outset, I would like to thank Shanta, who has brought this program to all of us. I think Ajay has been very dynamic in facilitating this in bringing this program to all the Foxians. It's a pleasure, Madam, Usha Madam, having you with us today. And Archana is, of course, always a sweetheart. It's so nice to have Archana with us. Thank you, Dr. Bharti, Dr. Kanchan, and the MTP committee, Dr. Richa, for having me with you all today. And I hope we'll enrich ourselves a little more than what we were. All the queries will be cleared today in this presentation.
Yeah.
Sriman, can I share my screen?
Yes, ma'am.
Yeah. Where is this keynote gone? Is my screen visible? Is it full screen or?
The screen is visible, but not full screen.
I don't know what this is. How to make this full screen now? This keynote is not there on my top. This is not going full screen. I don't see this keynote at all, play at all on my screen. Suddenly disappeared.
We can see your screen, Dr. Krishna.
It's okay, fine. Shall I go ahead?
Yeah, you should.
Okay.
Go ahead.
Okay. I was trying to make it full screen. So The objective of the module is to have a closer look at what are the new laws as has been already been introduced. We are going to talk about the laws which have come over in September 2021 and what are the changes that have been made in the previous existing rules. As Dr. Richa rightly said, unsafe abortions are lead to mortality, morbidity, and they hamper the women and girls' participation. And we all know that 8% of the maternal deaths per year, that is, as a leading cause of MMR, it is a third, abortions are the third leading cause. And 2 out of these 3 abortions are unsafe. That is what we are looking at. We are trying to target this and making it more accessible. The whole purpose of this presentation today is to make abortion care respectful and accessible to all the women of India. That is the whole purpose. And unfortunately, most of these pregnancy-related deaths are happening in late adolescence and early 20s. That's half of the deaths are before the age of 24. That is the problem. And when do we consider an abortion to be safe? Whenever there is appropriate method. When the methods are appropriate and it is done by trained people. When both of them are satisfied, we call the abortion safe. And if only one of the criteria is met, we call it less safe. And when neither of the criteria, that is neither the place nor the person is appropriate, we consider it as an unsafe abortion. And we all understand that it is a safe and comprehensive care which is mandated by law. That is the amendment which has been done in 2021. And the law has salient features. Previously, as per the previous act, there is a change. There was previously one person, that is one registered medical practitioner could do MTP up to 12 weeks. And between 12 weeks to 20 weeks, it needed the opinion of 2 providers. The 2 registered medical practitioners were supposed to sign together and take an opinion together and then take a decision. Whereas the 2021 Amendment Act has brought a change in this. Now it's enough if one registered medical practitioner is there, can decide up to 20 weeks of gestation to terminate a pregnancy. And only when it goes beyond 20 weeks, now the MTP Act has been extended up to 24 weeks. And when it is going between 20 to 24 weeks, you need the decision of 2 RMPs to terminate a pregnancy. So this is made to facilitate those people who are living in peripheries like smaller centers, people working in PHCs, where there may be only one gynecologist. They can still go ahead and terminate a pregnancy up to 20 weeks. So again, the other modification that has been brought about is regarding the vulnerable group of women. So now there is an act which previously the act would allow anyone beyond 20 weeks of pregnancy to get it terminated only if it is saving the life of the pregnant woman. Only when the life of the pregnant woman is at stake, we were permitted to do an MTP beyond 20 weeks. But the newer amendment, that is the 2021 amendment, says that this upper gestation limit has gone up from 20 to 24 weeks for a special and vulnerable categories. And who are these vulnerable or special categories? We will come to that a little later. And who are included under this group, will come to it. And not only that, there is an unlimited gestational age for termination is permitted in those cases of birth defects which are not compatible with life, but this has to be with the consensus of the medical board. So if the medical board is permitting us, and if the birth defect is not compatible with life, the upper gestational limit has been removed for such cases. So it is this vulnerable group of women whom we are going to define later are now able to approach for termination even later up to 24 weeks of gestation. So The other change has been brought about is for birth defects and anomalies. Like I said, it has been previously, the termination was only allowed up to 20 weeks, whereas the upper gestational limit is not applicable in case of pregnancy when there are anomalies which are diagnosed and are approved by the consensus of the medical board. And what constitutes the medical board, we are going to come back to it again. And so there is an increase in access to safe and legal abortion services for women who are seeking these. For many a times we are in this dilemma when they come at 20 weeks plus with incompatible fetal abnormalities, or late TIFA, or much later. There are some diseases which are diagnosed later. So like cardiovascular, some of the CNS, some of the renal, which are manifested much later. And in such cases, it would be very difficult for us previously, but now, and then we would only had the court, we could only ask them to approach the court and get permission. But now this can be done with the consensus of the medical board. Then the other modification is regarding the marital status. Previously, we used to always say that a condition of failure of contraception, that is failed contraception, was an indication meant for married woman or her husband. So this was applicable only to married woman or her husband. Now this clause has been removed. It is now any woman or her partner. So the marital status is not to be considered when you are when you are wanting to do a termination of pregnancy for failure of contraception. Especially this is useful in the present scenario where the legal age of marriage is going to be the planning to take it up higher. Then it becomes an important aspect, because here the failure of contraception is now extended to any woman or her partner. And the other one is additional. Previously also under the MTP Act, there was the privacy clause attached to it, but now this particular clause has been further strengthened. So previously, as per the 2003 regulation, information should not be disclosed except under authority of law regarding the termination of pregnancy. Now, even the name and other particulars of the women for whose pregnancy has been terminated shall not be revealed to anybody except to a person who is authorized by the law for the time being in force. So they have increased the privacy quotient of the clause. They have strengthened the privacy clause. So this gives you the needed respectful. This adds to the respectfulness which has been added to the abortion care. So now we are treating it's going to be a respectful bias-free services which we are going to offer to the woman who is seeking termination of pregnancy. So there is a priority for both confidentiality as well as safety. So previously it was name and other particulars of any women seeking abortion are to be kept confidential except to a person authorized in any law for the time being in force. This is just being reiterated again, that regarding the confidentiality. And the other important thing is the ground of failure of contraception is not limited to the married couple, but to any woman and her partner. So the changes now include adding this, defining the special or vulnerable category of women who are now eligible for extended gestational period for termination of pregnancy. Previously, it was 20 weeks. Now they have up to 24 weeks. And the RMP, that means the registered medical practitioner whose opinion is required, who can terminate this pregnancy, has also been newer groups of people have been added to that. And the power and function of the medical boards, which have to be formed for each state and are supposed to be mandated to these are the ones who are going to give evidence-based decisions regarding termination of pregnancy beyond 24 weeks for those pregnancies where the fetus has such abnormalities which is going to put its life under threat. So now coming to those vulnerable group, we were talking about a vulnerable group. So they have included 7 categories of women under these vulnerable group. One first is the survivors of sexual assault, the rape or incest. The second is women with pregnancy in humanitarian settings, or if there is any disaster or any emergency situations which have been declared by the government. In such situations, they still can go ahead with the termination. And if there has been a change in their marital status, for example, a woman has been divorced or she is now a widow, then she has a right to claim for termination of pregnancy. And women who are having physical disabilities. So these are the women who are come under the Disability Act criteria. So if they come under that criteria, then you can help them out. And then the 5th group is the mentally ill women who have mental retardation. The 6th group are the minors. Then the 7th group is whenever there is a fetal malformation which has a substantial risk of being incompatible with life, or if the child is going to be born, it would suffer from either physical or mental abnormalities and would be seriously handicapped. In such cases, also they consider it as a vulnerable group. So these 7 groups of people are considered as vulnerable group, where you can extend your termination of pregnancy clause up to 24 weeks. So who are the RMPs? Originally, when we are talking about RMPs, it means a medical practitioner who has assisted in 25 cases of medical termination of pregnancy after their MBBS, or had at least 5, and out of these 25, 5 of them they would have done independently in a hospital, or a practitioner who has done 6 months of house surgery in department of OBGYN, or a medical practitioner who has either a PG degree or diploma in OBGYN, or a medical practitioner who has experience of at least 1 year in the practice of OBGYN. So we had 4 categories of people who after MBBS fulfill either of these 4 criteria were eligible for doing the termination of pregnancy. So, but under the amended rules, there has been an additional category, and this is only for those terminations which are being done medically up to 9 weeks. So up to 9 weeks by the medical method, if you are planning to do a termination, then you have a 5th category, an additional category, that is an RMP who has an experience in the department of OBGYN for 3 months it is enough now. So, or they have done 10 cases, they were trained for 10 cases of MTP under the medical methods, under the supervision of an RMP in a hospital established or maintained, or a training institute approved for this purpose by the government. So if they have done 10 cases under proper guidance, or if they had worked for 3 months in a hospital in the department of OBGYN, they can do a medical termination of pregnancy up to 9 weeks. This is the 5th group of people who are now considered as RMPs. So till 9 weeks, you have 5 groups of people who can conduct this termination of pregnancy. The first is experience at any hospital for 3 months, or who have independently performed 10 cases of termination by medical methods under supervision of an RMP in a hospital established or maintained, or a training institute which has been approved. That is the first category. Or a practitioner has assisted an RMP in doing 25 cases of MTP, of at least 5 they have done independently, or who holds a postgraduate degree or diploma, or who has worked for 6 months of house surgery in OBGYN, or who has an experience at a hospital for a period of not less than 1 year in OBGYN. So you have 5 categories of people who are eligible for doing this termination of pregnancy now. That is up to 9 weeks. So after 9 weeks, they have dropped the first category. The rest of the 4 categories remain the same. So between 9 to 12 weeks, what they need is like the previous, all the 4 groups which have previously existed. That is, a practitioner who has assisted an RMP in the performance of 25 cases, or at least he has done, he or she has done 5 independently in a hospital, or who has a postgraduate degree or diploma, or who has done 6 months of house surgency in OBGYN, or who has worked in any hospital for a period of not less than 1 year in the practice of OBGYN. So these 4 categories, the 3 months or 10 cases is the only one which is eligible up to 9 weeks. So up to 12 weeks, all these 4 categories of people are eligible. Then after 12 weeks, that is between 12 and 20 weeks. So previously it needed the opinion of 2 RMPs, but now it is enough that if you have 1 RMP decides on the termination of pregnancy. And who are the people who can do that? A person who has got a postgraduate degree or diploma in OBGYN, or 6 months of house surgeons in OBGYN, or an experience of not less than 1 year in the practice of OBGYN. So anybody who has these 3 categories. So the previous category of working as a assisting for 25 cases and 10 at least 5 has been done independently, also has been dropped after 12 weeks. So the other 3 groups can do the termination of pregnancy between 12 weeks till 20 weeks, and the 1 RMP is enough to take a decision regarding this termination of pregnancy after up to 20 weeks. So this is a major change that has come about. Then again, between 20 to 24 weeks, now you need the consensus of 2 RMPs. So, and here you have only a practitioner who has a postgraduate degree or diploma, or who has 6 months of house surgeons in OBGYN, and or 1 year in the practice of OBGYN. They have been working in a hospital. But the difference between the previous and up to between 12 to 20 weeks is that you need the opinion of 1 RMP, whereas between 20 to 24 weeks, you need the opinion of 2 RMPs. So that is what is required. I hope I am clear. Then now coming to those pregnancies where they're seeking termination beyond 24 weeks. So here only 2 categories of people can do. That is either those who have had a postgraduate degree or diploma, or who had worked for not less than 1 year in the department of OBGYN in any hospital with and gained experience. And what is the additional clause that is most important here is that here you need beyond 24 weeks, it is a consensus or the opinion of the medical board is mandatory. So you have to do the termination only after you get the opinion from the medical board and their consensus, and with all safety precautions, along with appropriate counseling, and the place where the termination is being done has to be approved by the government. So under these conditions, you can go ahead and terminate the pregnancy. So, and who are there in the medical board? It is constituted by 3 people, a gynecologist, a pediatrician, and a radiologist or a sonologist. These 3 people constitute the medical board. And what are the powers of the medical board? They can allow or deny termination beyond 24 weeks of gestation period after considering and ensuring that the procedure would be safe for the woman at that particular gestational age. And if the fetal malformation has substantial risk of being incompatible with life, or if it would be born would suffer from physical or mental abnormalities to be seriously handicapped. And they have the right to co-opt other specialists. For example, they want a pediatric cardiologist or a pediatric neurologist or whoever it is. They can co-opt other specialists from into the board, and also can ask for any additional investigations before they decide on agreeing for termination of pregnancy. And FOGSI, with the ministry guidance and WHO support, as part of this RAC, are trying to operationalize and host medical board information on the website. Some of the states already have their medical boards in place, and some states still do not have not yet constituted. And in those places, it is very important that they go to the court and get permission before they go ahead with the termination. Then what are the functions of the medical boards? First, they will examine the women, the reports, and for whoever approaches them, and they give their opinion informedly, whether they want to agree or whether they want to reject the request for termination. And this has to be done within 3 days of receiving the request. So within 3 days, they have to say yes or no. And then to ensure that the termination procedure, once they have agreed upon it, and they, with all the safety precautions, with appropriate counseling, should be done within 5 days of the receipt of the request for medical termination. So they also have to ensure that it is done in a safe place with appropriate counseling and with all the precautions within 5 days. So that is a very important aspect the medical board has to take care of. So I think with this, we have come to the end of this thing. I hope you all have taken the pre-test, and then if you would give a post-test, you would be getting your certificates. And we are very glad to belong to a country where abortion is legal, and they are also trying to make it safe and respectful. It is a pleasure to have a government which thinks of women's health holistically and tries to think of the women's health in toto. Thank you so much for your patient hearing. Shall I stop my screen share? And shall we go any question and answers?
Yes, ma'am.
Yeah. So do we have questions in the chat box or?
Ma'am, there is one question. RMP criteria for MTP up to 9 weeks.
So
She has already told. You have already told me.
Yeah, that is already
five.
The fifth category is added, where they just need to have 3 months of training, or at least have done 5 cases under supervision for medical termination. That is only up to 9 weeks. This is an additional add-on to the previous already existing ones.
Thank you, ma'am. Thank you. You have explained everything very clearly.
Yeah.
But there is somebody saying that, can you give these PPT? Can you share this PPT?
There is one more question in the chat box, please.
Yeah, one more question. And she's asking, please explain vulnerable group again.
A vulnerable group, they have included the seven groups of people in the vulnerable group. And in the 7 groups, it is all those women who are handicapped, those women who are had a pregnancy due to any rape, incest, or any such thing. Or even if the government has declared an emergency and has given permission, like for example, disaster or something, and they have given permission. And those group of women where they are minors, and those group of women who are disabilities.
Change of spouse.
And change of widowhood, or if they have widowhood, or if they are divorced. I think totally 7 categories have been this thing. And I think the next session will tell you, I'll give you all where all the information is also available. I think Ajay, you can where exactly can get the details of this information?
All of this in the subsequent presentation, there are links to the WHO document and the government document, but one can always get that from the Ministry of Health and Family Welfare website, where these documents are there, or WHO doc. I mean, what has happened is that WHO and FOXI and AOG put together, and Government of India as a lead, has summarized all of these big books and tried to give everything to you in a nutshell. So if you want to do a little more reading, you can always visit those websites and download them. But I think for the current purposes, I think what we have presented here should, sail you through going forward. Krishna Kumari, it's such a wonderful, to see you once again online after having physically met you recently. Thank you so much. Saroj, good to see you. Kanchan, good to see you here. As well as Shaili, good to see you also. Yeah, I know all of these people because of the several works that we have been doing in the past. And I'm really delighted, Kanchan and Bharti, for the 2 of you who met me very briefly, precisely for 4 minutes in the lobby of the AICOG meeting, and both of you have so proactively organized this entire training program with almost 86 participants as of now. So a huge congratulations to both of you for having this possible. A couple of operational things, Usha ji, before I move on and hand over to you and to Kanchan. Essentially, I want to make sure, I think there are two more questions, Krishna Kumari, before I address that. One question is, I'm MS, Latika is asking, I'm MS in OPS Gynae, still I have to register myself with the CMO office?
That is the register, your center also has to be registered where you're doing. So the person in center are always have to be registered. The same law, before also we were doing the same thing. And every MTP we will have to record it, and then monthly census has to be sent to the DM and HO as before. So including the medical terminations have to be recorded and sent to the DM and HO. That is very important.
And there was, sorry, Kanchan, I'm just hijacking your efforts.
No, sir. Thank you so much.
This is for you, Ajay. They have attended, Dr. Mrudula has attended it, but she did not receive the certificate.
Yeah, I mean, this is not
complete the post check.
I have already written this for Neeti as well. This is not the forum for you to address your operational issues. Please send us an email and it will be addressed.
And if you haven't done the post exam, maybe that could be one of the reasons. Now, please now do the exam, so then you will get your, because I got my certificate in the beginning. Yes. So I know, so without a pre and a post test, you will not get it.
Yeah, one is that. Two is, please ensure your email is correct. Email that you registered and email with which you're submitting your post test, both should be the same, because it is automatically system generated. We have no role to play. And whenever you're, please, even after today's meeting, in case you do not get your certificate, please send an email. I put the email in the chat box, foxy.ractraining@2021@gmail.com. Kanchan, I'll request you towards the end of the session, you can copy paste it once again for everybody's benefit here. And also to mention, many a times the certificate has reached you and it is from an unknown source. So it is lying in your spam folder. So please do check your spam folder also before you send it, okay? And when you're corresponding to us for non-receipt, please mention the following two things in your mail. The date you attended, the date you attended the program, and two, the date you submitted your post test. This will allow us to trace your record immediately and give your feedback and response immediately. Just so all of you should know, each and every one of the faculty over here, Jamna, sorry, I didn't call out your name, I didn't see you. Each and every faculty here has really worked hard, and each and every society and their members have worked very hard. And a huge congratulations to each one of you, because today we have trained about 8,000 Foxians across the country through this entire program. So huge congratulations to everyone. And the operational bit essentially is Sriman or Kanchan, at the end of the session, will be posting one link in the chat box, which link, once you click it, you will be taken to the post test and feedback. Click on it and submit it immediately. Do not wait for it. It will take you precisely 4 minutes to do it. So 4 minutes after 2 hours, just finish that and you're done with it, and you will get a certificate without having to bother any one of us or yourself with this. So Kanchan, I'll post it to you one-on-one. Post it only towards the end of it, because there's another criteria of attendance as well. So we shouldn't happen that people submit the post test and leave the meeting. Again, the system will not recognize those people and it will not get issued. So that will be another bother for you, Kanchan. Yeah, with those little words, thank you very much for hearing me out and patiently listening up to me. And please carry on with the program. I may have to leave, but I'll keep joining back and again, because there are 3 programs happening in parallel right now.
I know.
Thank you. Thank you so much, Ajay sir. And Ajay sir is very quick in support. I know whenever I have any query, just a sudden reply, quick reply comes from Ajay sir. Thank you. Thank you so much, sir. So now we are moving to our next talk. And For next talk, I would like to invite the chairperson, Dr. Alka Sethi ma'am. Ma'am is a secretary of Jhansi Option Gynae Society and is a very active person and very warm person. But Alka ma'am, are you there? I can see the name, but I cannot see the video. I think she's having some problem joining. So I would invite the speaker, Dr. Shaili Agarwal. Dr. Shaili Agarwal is very dynamic person. I always see her busy in some or other work, and she's young, dynamic, and professor, and she's hardcore academician. So Shaili Agarwal, Dr. Shaili Agarwal ma'am, the stage is all yours, and kindly go with your talk.
Thank you so much, Dr. Kanchan, for your kind words. Let me share my presentation. I hope it is visible.
Yes.
Okay, perfect. It is in the slideshow mode now?
Yes, it's in slideshow mode.
Okay. So after the updates on this Medical Termination Act by Dr. Krishna Kumari, we are here with the module 2, that is the recent updates in technology of safe abortion. So in this session, we will overview the existing guidelines. Then what are the assessment we have to done pre-procedurally? Then what are the methods for abortion? It is medical and surgical. We will discuss it in the details. So as ma'am has told, all the guidelines of India and Ministry of Health and Family Welfare are inspired by the WHO guidelines. We have incorporated all these guidelines into our national guidelines. And these are available on the WHO site as well as on the Ministry of Family Welfare and Health of India. So you can download it from there also. And then there is a major historical change in this MTP Act. It was amended in 2021, and law was changed on 25th of March 2021, and the rules were changed on 24th September 2021. So the gestation age.
Shriman, kindly mute other person. There is noise.
So the upper limit of the MTP was changed from 20 weeks to 24 weeks, and even in special vulnerable group, there's no upper limit for these things. So a major breakthrough happened in last year only. Now all the guidelines have 3 key areas in the management of abortion safely. As I told you, pre-abortion care, then the care during the abortion, and also equally important is the aftercare follow-up, including the post-abortion contraception and counseling. So we have to take a detailed medical history of the patient, then proper physical examination, then if tests are required, then laboratory and other investigations, and also we have to discuss the contraceptive option for the later period of her life. And after these things, the women choose to have abortion, she should be allowed to choose from all the methods available to her that are appropriate for her based on the duration of gestation age and her medical condition. So first part is pre-abortion assessment and counseling. So if she is seeking first trimester abortion, that is up to 12 weeks, we have to take a detailed history. We have to do a general physical and pelvic examination to rule out an infection or any other problem. Then lab investigations which are required, and also the decision-making information on the method of abortion and the counseling regarding post-abortion contraceptive. First and foremost is gestation age determination by the LMP and physical examination. We all are gynecologists, we all know how we assess the gestation age. Just to summarize it, in initial part of the pregnancy, from 4 weeks onwards, there is an increase in the uterine size by 1 centimeter per week, and by 12 weeks it reaches to abdomen beyond the pelvis. Then at 16 weeks, the uterus is midway between the pubic symphysis and umbilicus, and then after 20 weeks, it is at the level of umbilicus, and then it reaches. Then it increases in height 1 centimeter per week above the pubic symphysis. But there are some conditions which can limit the date of uterine size by physical examination. If the patient is having uterine malformation in the form of fibroids, or she is having multiple gestation, or she is having marked uterine retroversion, or she is having obesity in which we are not able to palpate the uterus, or molar pregnancy. So these are the conditions in which we can have the smaller uterus than the gestation age if she is not pregnant at all. If it is her menstrual dating is not sure, she is not sure about her LMP, and it is a case of ectopic pregnancy or abnormal intrauterine pregnancy, that is spontaneous or missed abortion. There are some conditions in which uterus can be enlarged beyond the expected size. Again, if the LMP is wrong, it is a multiple gestation, there are uterine anomalies or molar pregnancy. So we have to keep in mind while we are doing dating with the physical examination. Then come to the pre-abortion investigation. As such, according to guidelines, no routine lab test is a prerequisite for abortion services. But some tests may be performed as per the individual risk factors or a finding on your physical examination. So as such, no test is required before giving the service of abortion to any patient. First and foremost is pregnancy test. If you are not sure of the pregnancy, patient is saying, but on examination, you are not sure whether she is pregnant or not. If you're suspecting anemia, then hemoglobin is required. Otherwise, as such in guidelines, they do not say that hemoglobin mandatory hai. Then RH blood group testing, where you have facility of administering RH immunoglobulins if the patient is RH negative. HIV testing and counseling is again optional, not mandatory. STI screening while doing your pelvic examinations, and other medical tests as indicated by medical history. If you are seeing it's the case of chronic hypertension, then you can go for the kidney function test or liver function test. Ultrasound is not necessary unless to diagnose the pregnancy which is not certain or suspecting, or you are suspecting ectopic or molar pregnancy or missed abortion on your physical examination. Then comes the pre-abortion counseling. Ask thoughts about the termination of pregnancy, whether she is sure to terminate this pregnancy or not, she is in dilemma, or she has made up her mind or not. Then reason for terminating. What is the reason? You have to inform her early abortion is safe. Lesser the gestation is, more safe is the abortion process. Then she has to accept the importance of a trained provider performing the procedure for safety, because unsafe abortion can lead to many complications. Then available methods of abortion. It is medical method, it is surgical method. We have to tell each and everything. Risk and warning signs associated with the abortion method. If she is choosing medical abortion, then we have to tell her that there are some warning signs in which she has to immediately report to the center. And then this is very important. We have to tell her the importance of post-abortion contraception, because without contraception, she can get pregnant as soon as 14 days after an abortion. So we have to tell her very, very clearly that she needs to use some contraceptive after the abortion process. The resumption of her normal activities, including sexual intercourse after the procedure, and any other follow-up care if she needed. You have to document the informed written consent, and she has decided to accept post-abortion contraceptive or not, it has to be documented in the form. But even if she is not willing for contraception, she will be provided the abortion services. We cannot deny abortion. If कई बार देखते हैं कि हम लोग मेडिकल कॉलेज में हैं, हमारी रेजिडेंट्स बात करती हैं, वो कहती हैं कि अगर तुम कॉपर्डीन लगवाओगे तो हम तुम्हारा अबॉर्शन नहीं करेंगे. Then patient comes to us. तो उनको ये भी बताना है कि even she is not willing, but we cannot deny the abortion. We have to counsel her in a way that she accepts any method of contraception. Now coming to the clinical management of abortion. We all know in first trimester, the global recommendations are it can be with the medical abortion, if it is on misoprostol, then we can do it with the misoprostol only, and the surgical with the vacuum aspiration. More than 12 days, global recommendations are again with the medical abortion and then dilatation and evacuation. But at any point of time, dilatation and sharp fertilization is never recommended. It is always the vacuum aspiration of dilation and evacuation. So, Government of India recommends medical abortion only up to 9 weeks. Up to first 7 weeks, that is 49 days, Government of India guidelines says mifepristone should be given to orally, then wait for 24 to 48 hours, and then give misoprostol 800 microgram, that means 4 tablets. It can be given sublingual.
Hello, Shelly ma'am. Hello.
Maybe network issue, madam got disconnected, ma'am.
Okay, I think she lost the connection. So we can wait for a few minutes. Otherwise, we can.
Yes, we can wait for a minute or two. Otherwise, we can move on to the next presentation and she can come back and complete it later.
Yes. Jamna ma'am, are you here?
Yes, yes.
Ma'am,
Yeah,
we will wait
I am
for.
here.
Good evening, ma'am. Good evening. I think
Good
we are waiting
good
for
evening.
Shelly ma'am. If she doesn't join in two few minutes, 1 or 2 minutes, then we will start with your session, ma'am. She can let us deliver it. See, weather is not good in this area today evening. That may be reason. So, I think. I think we can start with the Jamna ma'am's talk. And to invite her, I request Pragati ma'am, please invite Jamna ma'am, introduce Jamna ma'am. Pragati ma'am, are you here? Pragati Agarwal ma'am?
Yes, yes, I am here.
Yes.
I don't have a CV.
Okay, ma'am, introduce verbally. We all know she is a very good speaker.
Okay.
That's a wonderful one.
Our next topic is WHO 7.
Never toolkit. Yes.
Toolkit Safe Abortion Values, Evidence and Rights. And the speaker is none other than Dr. Chandna Devi. I invite her for the talk.
Hello.
Oh,
hello, Dr. Chandna.
Shelly ma'am is back, I think.
मेरे प्रॉब्लम हो गई थी एक्चुअली उसमें तो
okay.
Should I continue?
Yeah,
Yes,
Jamna
yes.
ma'am, can we continue with Shelly ma'am's talk? Hello? Hello? Ma'am?
Yeah, she can.
Okay, thank you so much, ma'am.
Yeah, she
Thank
can.
you so much. Okay,
Yeah,
okay.
she can.
I have to share my screen again.
Do it, ma'am. Then share your.
I think Jamna ma'am की screen share हो रही है.
Okay. Sriman, please help out with the technical glitch.
I think I stopped.
She has stopped her screen sharing.
Just a
But
second.
Dr.
Just a
Shelly
second.
will share her screen.
Okay, just a second. May I know from where I was disconnected? Should I start with from the beginning or?
No, ma'am, I think you can start from where you got interrupted.
I think we were on this slide.
Yes, yes.
Okay, thank you. Very sorry for the inconvenience. So in 7 to 9 weeks, that is between 49 to 63 days, it is the mifepristone 200 milligram orally on day 0, and after 24 to 48 hours, it is misoprostol, which can be given 800 micrograms sublingual or buccal. So in first trimester abortion, we have both the methods. It can be done by the medicines, that is medical abortion, or it can be done surgically. So first is medical abortion. We all know the mifepristone is anti-progestin. It inhibits the action of progesterone. It interferes with the continuation of pregnancy. An initial oral dose of mifepristone is followed by misoprostol. It is a prostaglandin E1 analog, and this misoprostol causes cervical softening, uterine contractions, and ultimately the expulsion of conception products. So regime is, on day 1 we will administer mifepristone orally, and if the patient is RH negative, we are the facility of NTD, then microgram NTD should be given patient on the day 1. Then on day 3, that is after 48 hours of mifepristone administration, if the patient is up to 7 weeks of gestation, then 400 microgram misoprostol, that is 2 tablet, sublingual, buccal, vaginal, or oral. All the 4 routes can be given. Or if she is between 7 to 9 weeks, then a dose is 800 microgram, but it should not be given orally. It can be given sublingual, buccal, and vaginal. Then in addition, we can prescribe analgesics for the pain, antiemetic for the nausea and vomiting, and we have to offer the contraception. Then the follow-up is arranged within the 15 days, in which we confirm that all the products has been expelled and the process is complete, and we have to offer the contraception if she has not chosen any contraception on the second visit. Then what is the difference between these routes? If we give the oral routes, pills are swallowed. It is recommended only up to 7 weeks of gestation, not beyond that. Side effects are diarrhea, nausea, fever, and chills. Buccal, in which the pill is placed between the gums and cheek and is swallowed after the 30 minutes. For 30 minutes, she has to keep the tablet in the buccal region. In this, the patient can experience more fever and chills than compared with the vaginal route. In sublingual, the pills are placed under the tongue and they have to be kept there and swallowed after the 30 minutes. There are increased chances of fever, chills, diarrhea, and vomiting as compared to the vaginal route. This sublingual route has the fastest onset of action and highest plasma concentration level among all the routes. In the vaginal, we place the pills in the vaginal fornices, and woman is instructed to lie down for 30 minutes before getting up. And pill fragments can be visible, and it has the lowest rate of side effects. There will be less number of nausea, fever, chills, or diarrhea with this route. So this is the buccal route. The tablets are placed between the gums and the cheek, and this is the sublingual route. So WHO drug regime is that if less than 12 weeks, mifepristone is given per orally 200 milligram, and misoprostol is given after 24 to 48 hours, 800 microgram buccal per vaginal or sublingual. There is also one regime which is WHO has given. This is the only misoprostol regime. In less than 12 weeks, it is given 800 microgram buccal per vaginum or sublingual. Vaginal bleeding is acceptable for 2 weeks. We have to counsel the patient that 2 हफ्ते तक bleeding हो सकती है, and such bleeding can last up to 45 days, but it is very rare. So she has to report it if she feels she has bleeding for more than 15 days. So this service should be available at the primary care level with referral system in place for the all required higher level care. So this is important. This center should be linked to a referral system. If she has emergency, she can be referred to that place. Additional services may be provided to individuals seeking medical abortion, in which we can do the counseling and testing for STIs like HIV, abuse support services. If she is a victim of domestic abuse, that she can get the support during this time, psychological or social services, and other specialist health and medical services, because this is the only contact of time we can have with the patient. If she is anemic, we can provide the iron tablets. If she needs any pain medication, we should provide it at the same time, and emotional support if needed. Then follow-up care as per guidelines. Follow-up routine is not required, not necessary after the uncomplicated medical abortion using the mifepristone and misoprostol. But a routine follow-up visit is recommended in the case of medical abortion in which we are giving only the misoprostol. A follow-up visit of between 7 to 14 days after the procedure is offered to provide the contraceptive counseling and emotional support and address any medical concerns. So as such, it is not necessary, but it should be offered for the further contraceptive counseling. In follow-up care, we have to assess the woman's recovery and ask for any signs and symptoms of ongoing pregnancy. We can review the available medical records and referral documents. We have to ask about any symptoms experienced since procedures. We can perform a focused physical examination if she is having any complaint of discharge or pain. And we have to assess women's fertility goals and need for contraceptive service if not provided earlier. If the family is complete, we can counsel for the permanent method. If she wants spacing, we can counsel for the spacing methods. So in the summary, we have to do on the first visit, physical pelvic examination, confirm the eligibility because it is only up to 9 weeks in India. We have to give mifepristone and NTD if patient is RH negative. Tell the woman she has to come for misoprostol administration after 2 days. Contact address and phone number of the facility where she can go in case of any emergency if it is required. Record her experience of any side effect on the MMA card. MMA card is given to the patient in which there are diagrams. If agar pet mein tez dard ho, bleeding ho, to she has to report it. And then less than 3% women may completely expel with the mifepristone alone. But in this case also we have to complete the regime. So she should be advised, even if bleeding ho chuki hai, she has to come for the day 3 to complete the procedure. On the second visit, that is day 3, we give misoprostol up to 7 weeks. 400 is a dose. Observe for the 4 hours. Analgesic can be given and counseling can be done. We have to tell the woman that mean period of bleeding is between 8 to 13 days or mota 2 hafte. Possible side effects can be nausea, vomiting, diarrhea, headache, fever and dizziness. Report in case of excessive bleeding, pain in abdomen and fever. And again, we have to tell her that she has to report if there's no bleeding after 24 hours of the misoprostol. In this, we can consider her for the additional dose of misoprostol, or we can advise her surgical evacuation. 75% of women abort within 4 to 6 hours after the misoprostol administration. On third visit, that is on day 15, we have to do the pelvic examination to ensure the completion of the abortion process. Contraception options can be discussed, in which we can give her hormonal methods, condoms, IUCDs, and if she wants permanent method, then sterilization after the next menses. We have to tell the woman about the immediate return of fertility. She can get pregnant even after 14 days. So she has to adopt any contraceptive method. She has to report back if there is no period for 6 weeks, because it can be an ongoing pregnancy. Ultrasound is required only if the examination does not confirm the completion of process. If it is on examination, there is no bleeding, also closed, then no need of ultrasound. Side effects and complications: the pain, nausea, vomiting, diarrhea, and infection, and these can be dealt with. We have to be respectful for every woman, non-judgmental communication. Verbal support is very important. Adequate counseling should be given. Support person, there can be Anganwadi worker, there can be ANMs who can act as a support person. If she is not responding all these things, then we can give the ibuprofen 400 milligram. Persons pain with failure to respond to these drugs for several hours. It warrants evaluation of other causes such as ectopic pregnancy, ongoing infection, or incomplete abortion. So each and every complaint should be taken seriously. Nausea, vomiting are usually self-limiting, so just reassure her, or you can give the antiemetics. Diarrhea is also self-limiting, just reassure the patient that it will be correct on its own. If it is infection, then you have to start the antibiotics. Then there are actions, what we do if it is failure or there's incomplete. If there's failure of medical abortion, she can be offered with a vacuum aspiration or repeat MMA. These are in the guidelines, but practically we do not repeat the MMA. I think we can discuss it later. If it is incomplete abortion, then observe unless the bleeding is heavy. If the bleeding is resolved, uterus is normal size, we assume that the abortion is complete, or we can give the misoprostol repeat in the repeat dose. But after all these things, the bleeding continues, then we have to offer her surgical method to complete the process. So this is the flow chart of excessive bleeding PV. She presents the excessive bleeding. So what is excessive bleeding? Bleeding more than her menstrual cycle, and she is soaking 2 pairs in 1 hour for the 2 consecutive hours. We have to observe the patient. If the bleeding decreases over time, we can offer routine care by keeping the watch on her vitals and bleeding PV. If it is normal, then we can discharge her. But the bleeding does not decrease over time, then we have to monitor the patient, we have to do the PV to rule out any POCs in the cervical canal and digital evacuation. If after this procedure woman is stable, bleeding reduces, then we can monitor her and then we can discharge. But if the bleeding continues even after all these things, then urgent USG should be done to see the presence of POCs. If it is minimal residual bits, we can wait and watch, or we can give the misoprostol sublingually in the dose of 600 orally or 400 microgram sublingually. If woman is not stable, then we have to go for the surgical evacuation. If the pregnancy is continued, it has failed, then we have to offer her surgical evacuation, because after the MMA, it is not advisable to continue with the pregnancy because of the risk of congenital malformations. Then this is very important. All the MMA should be recorded and reported to the district authorities, because this comes under the purview of MTP Act, and the documentation is similar as required for the vacuum aspiration procedure. So it is mandatory to fill all the following forms. Form C, that is consent from the patient. Form 1, that is RMP opinion, that she is fit for the abortion. Form 2, that is monthly reporting form, which has to be sent to the district authorities. And Form 3, that is admission register for the case record. So all these forms has to be duly filled and sent to the respective authorities. Now coming to the surgical abortion, that is the MVA or EVA, manual or electrical. Vacuum aspiration is recommended technique for surgical abortion for the pregnancy up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. And the procedure should not be routinely completed by the sharp curettage, because the pregnant uterus is very soft and fragile. It can lead to the perforation. It is not recommended. Vacuum aspiration method, this is the manual vacuum aspirator, MVA syringe. And the procedure of abortion is performed same regardless of the type of vacuum used. We can do the MVA, we can use the EVA. So this MVA is a handheld aspirator used to generate vacuum, in which we have the cannulas of different size from 4 mm to 12 mm diameter. Cannula can be used in multiple settings, including those without the electricity. So the beauty is this can be used without the electricity. It has very easy grip cannula, size corresponding to gestation age. Like 8 mm cannula is used for the 8 weeks. There are different colors coded cannulas. In electric, we use electric suction machine and we couple it with the Carmen's cannula according to the gestation of the pregnancy. Then comes the role of cervical priming. It may be considered for the woman with pregnancy of any gestational age to prepare the cervix, to make it soft and easy to dilate with your dilators. The recommended methods for cervical priming before surgical abortion in first trimester are: it can be oral mifepristone, 200 milligram, 24 to 48 hours prior to the procedure, or we can use misoprostol, 400 microgram sublingually, or 2 to 3 hours prior to the procedure, or we can give misoprostol vaginally in the dose of 400 microgram 3 hours prior to procedure, or we can use a laminar trent also intracervically. It is placed 6 to 24 hours prior to the procedure. Mostly we all use misoprostol. The pain management plan for the vacuum aspiration is important component of the quality abortion care. We have to counsel the patient, baat kariye usse, because verbal anesthesia is the best. Reduce pain and anxiety that makes the woman comfortable. So the two components of pain management are non-pharmacological and pharmacological. In the non-pharmacological, it is the psychological support, explaining each and every step to the women in advance. कि अब आप एक speculum लगाएंगे, we'll hold the cervix, now we'll going to insert this dilator or Carmen's, and performing the procedure gently and smoothly. Encourage the woman to relax and breathe deeply. Pharmacological methods are: for anxiety, we can use the anti-anxiolytics, or we can give a short general anesthesia. For anxiety, diazepam 10 milligram orally 1 hour prior to the procedure, or it can be given IV 2 to 5 milligram IV 20 minutes before the procedure. Duration of effect lasts for 4 to 6 hours. Side effects are disorientation and dizziness. For cervical dilatation, for that we can use the lignocaine or local anesthesia, or we can give the NSAIDs. And for uterine cramping, ibuprofen can be used in the dose of 400 to 800 milligram 1 hour prior to the procedure. Side effects are gastritis. The steps of MVA, in which we have to prepare the instrument, then prepare the patient, then perform the cervical antiseptic preparation, because all the procedure should be done under antiseptic conditions to prevent the infection. Administer the paracervical block, then dilate the cervix, gentle dilatation, and then insert the cannula. Then we withdraw the cannula 1 to 2 cm from the fundus to remain it inside the uterine cavity. Then the cannula is rotated in the 10 to 2 o'clock position with the smooth gentle motion. And then the vacuum is released with the vacuum button so that all the components comes in the syringe. The signs that tells the uterus is empty, all the products has been removed. When we get the red or pinky foam without the tissue passing through the cannula, we are getting gritty sensation over the surface, all the walls of the uterus. Cervix is gripping over the cannula and uterus is contracting around the cannula. So patient can experience the uterine cramps. So after this, we have to inspect for the tissue and then proceed with the contraception methods. If she has opted for the IUCD insertion, we can give the IUCD insertion in the same setting. If she has opted for the sterilization, we can do the sterilization in the same setting. And the instrument processing. All the instruments should be soaked in the chlorine solution, 0.5% bleach solution for the disinfections. Then the post-procedure care. Monitor her for any complications and provide management as needed. She will leave the health facility when she is stable and meets the criteria for the discharge. She is fully oriented, she is having no pain, she is having no excessive bleeding. Ensure that the patient has all the necessary information, medication prior to leaving the facility. She has all the information. If she experiences any pain, undue bleeding, she has to report back. Document all the outcomes of treatment, including any adverse event, in the facility register and client's record card. If कोई complication हो भी गई है, तो it has to be mentioned clearly in the records. Then after care, management of abortion complications. If it is a case of incomplete abortion, infection, bleeding, ongoing pregnancy, they has to be managed accordingly. Contraceptive information should be provided and offer contraceptive counseling and methods. assessment of any other sexual or reproductive health needs that may require additional care. So as there's no new recommendation is no routine follow-up is required unless the meso-alone regime is used. So in summary, India has made a historic progress in improving the access to safe abortion. Technical updates, there's not much change. These are the same as in the last decades. As providers, it is up to us to ensure the safety and quality, especially in context with the amended law. Along with the safety, we need to focus on the respectful abortion services. We have to be non-judgmental. We have to be very respectful when we are dealing with such patients. Every client, public or private, we have the opportunity to inform her, to educate her, and to equip her with the proper information on contraceptive and counseling. So each and every opportunity should be grasped for the contraceptive counseling. So all of you are requested to complete the post-test and feedback after the session. Only that we will be getting your certificates, and certificate will come on your mails after 1 week time. So this was all from my side.
Thank you, Dr. Shelley, for such a wonderful lecture. You very clearly pointed out all the techniques, first trimestral techniques. And it's very true that if we follow the guidelines, then we are safe. Because unsafe abortion is the leading but preventable cause of maternal death and morbidities. It can lead to physical, mental health complications and social and financial burdens for the woman. And so we have to be very particular that people don't resort to unfair or unsafe means. And lack of access of safe, timely, affordable and respectful abortion care is very critical public health and human rights issue. So it should be available whenever the woman requires. She should be offered the services. Very rightly said, and very nice lecture. Thank you for, sorry I was late, there was some Wi-Fi problem, connection problem. So, but it was a very informative, very nice lecture. Thank you very much. And
thank you so much, Alka ma'am. Thank you so much. And I am extremely sorry, Jamna ma'am, आपको share करके हटाना पड़ा.
अरे नहीं भाई, कोई बात नहीं, ऐसे होता है. Don't worry.
Thank you, Shaili ma'am. Thank you, Alka ma'am, for joining. And now we move on to next session because I think there is no question in the chat box. And the chairperson for the next session is Dr. Kiran Chandana ma'am. I cannot see ma'am. I think Kiran ma'am is here or not? She's also having some.
Hello.
Hello, hello ma'am. Your video is not on, ma'am. Kiran ma'am. Hello. Hello. Kiran Chandana ma'am is a secretary from Faridabad society, and she is very warm, very loving person, and very active person. And I think ma'am is having some technical issue right now. So we will move on with the talk. I invite Jamna Devi ma'am to kindly.
Thank you so much. Yeah. Thank you so much. I think I'm privileged to be invited. Sriman, can you share the screen, please?
My screen visible, ma'am?
Yes, please. Yes. I think screen is visible to everyone, please.
Yes, ma'am.
Thank you. So after Krishna has told us about the laws and the new amendments, rules and regulation, and Shaili has given us a very good input of the medical management and surgical management. Now I'll take you through this SAVOR. SAVOR is nothing but safe abortion values, evidences, rights and respect. So this is the third module. Yeah, next please. So this module is aiming at that definition of respectful abortion care according to the world as the norms and stigma which affects our services, and provides WHO SAVOR resources so that we can do respectful abortion care. Next slide, please. So, as you all know, the momentum has created. Law has changed and it has to be disseminated. So who better than Foxy can do this? So this is the largest provider base, so that abortion care can be disseminated to its providers. And because of COVID, we had a very good online training was possible, and it was done very successfully. And so that all providers could get this information. And apart from this, now because of this COVID, this medical management abortion has tremendously increased. And we all know that it is very early, safe, and there, most importantly, no headache of PCP-NDT conflation. And along with that, patient safety, respect, and quality, which matters more than ever. And we all have to play a role in this respect. Next slide, please. So what is respectful abortion care? Next slide. So this respectful taken from maternity care, which WHO has coined it, and it nothing but it refers to that maintains safety, dignity, with that confidentiality, and ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all type of abortions, which Shaili has told wonderfully. So simply it means that respectful care means that we as providers and or as a patient treated with dignity, empathy, and compassion, regardless of your race, gender, socioeconomic status, or reproductive history, whether it was failed contraception or miscarriage or something. So, and whenever you see a woman, if she's feeling that it's not right, encourage her to speak up. And as health professionals, it is our duty to listen and support. And communication is the key. And here I would like to tell all the members here, these words hold good for any case which we encounter, not only abortion, but I think any case, because this will lead to less medical legal issues in our practice. Next slide, please. So what are the norms and stigmas? You know, earlier, whenever a young girl and a boy walks into our clinic, we used to become very judgmental and biased. But after going through this session, I think I have changed. Next slide, please. So the stigma and the norms will perpetuate disrespect and abuse. What are these
social norms are the unwritten
encountered? Next slide, Sriman. So physical abuse.
Madam, this is the video. Should I play or?
No. Move on to the other one because it will take
rules of behavior.
Okay. So what these are the physical abuse, like slapping or intimidating physically, verbal abuse, non-consented care, shouting, screaming, sexual abuse, to show power, taking advantage of it. Then we have failure to meet professional standards of care, poor rapport between women and the provider, then the health system conditions and constraints. Now, all these are the disrespect and abuses. Then what are the rights of every woman? She has a right for freedom from harm and ill treatment. Then she has every right to information. Archana, I think you have to mute yourself. Archana, please mute yourself.
रास्ते में यूं सब्जी लेने की कोशिश कर रही हूँ शाम के लिए।
हम सब आएंगे खाने के लिए आपके पास।
Shriman, do something, please.
What sabzi she's going to buy, we should ask her. Okay, the right to information is very important. Then protection under laws, various laws, MTP, POXO, then informed consent. She can refuse also, and we should respect her choices. and preferences with dignity, and we should give quality of care. And the right to timely care, healthcare, and to the highest attainable level of health is her right. Liberty, autonomy, self-determination, and freedom from coercion are all her rights for every woman. Next slide. So what are these? There are domains of respectful abortion care. There are 12 domains. So one is being free from harm and mistreatment, which we have already known. Then we have to maintain the privacy and confidentiality. And confidentiality is one of the main thing in MTP laws. Then you have to preserve the women's dignity, then respect her choice, engage with effective communication, and that is you have to have your soft skills, then providing information and seeking informed consent, ensuring continuous access. We should give her support whenever she needs it. And apart from that, we have to enhance the quality of physical environment and resources, and provide equitable abortion care, availability of competent and motivated providers. This is very important. And provision of contraception advice and commodity should be available for her. Continuity of care and counseling. I think all these 12 points hold good for any case, because I am a medical legal advisor for in Telangana. So I say that all these things are so wonderfully written. Next slide, please. So it is now time for us to strengthen this implementation which has come. So when you are doing from 12 to 20 weeks, or from conception to 20 weeks, you are the only one provider. So the responsibility is much more. So you need to do counseling, contraception, referral, and compassionate care. Then when the two RMPs are going to deal with 20 to 24 weeks for special cases, then there you need to be sensitive and you should be judgment free, and timely services should be given. And as I told you, confidentiality and safety is the priority, and respect gets respect. So this should be, remembered by all of us. So as providers, we need to be mindful of socio-cultural aspects. Next slide, please. So there is another video. I think we'll skip that video. We'll skip the video. So WHO training for safe abortion values, evidences, and rights. That is Saver Toolkit. They have these links. You can go through these links. They are really wonderful. And then you can take a screenshot. Next slide. Sriman, next slide. Yes, these are the links. I think all of us should experience these links. They are really good. Next slide. So as we have seen that WHO first in 1970s talked about unsafe abortions, but in 2000 they said safe abortion. But now in 2020, they talk about respectful abortion. So let us all recap. So we'll have some questions, and I request all of you to answer these in your chat box. So we'll just go through these questions. Yes, next. So the first one is, next slide. Yes, according to World Health Organization, restricting access reduces the number of unsafe abortions, whether it is true or false. Fastest finger first. Please put your answers in the chat box. What do you think? Is it true or false? Yes, I could see only. Yes. So according to World Health Organization, restricting access reduces the number of unsafe abortions. Next slide. Let us see the answer. Next slide. Yes. See, it false. Because if you reduce the access, then there will be more unsafe abortions. Yes. Next. So we'll go to the next question. Thank you for answering. Next question. Yes. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? I think all of you know this. Yes. Now, here, show the answer. Yes, no, because we can't say yes, because we have to respect her choice. And then if she want to get an abortion done, we have to do it. That is what the whole theme of this respectful abortion. Next slide, please. Next slide. Yes, these are the ones. And I think there is one more, I think. Sriman has missed it. I will tell that. The MTP Amendment 2021 requires a minor who is below 18 years, to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. Next slide. I think this is the question. So whether true or false, I think this question is not there. The MTP Amendment 2021 requires a minor below 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. No, she doesn't need to go for, we need not take the consent from the parents and the guardian, because we will be taking this case under POCSO. So POCSO will be taking care of all the needs, whatever need to be done about this minor, and they will be in charge of all the legal issues. So we don't have to insist for, because they will be taking care of it. So here we don't need to take a consent from parents and guardians. This is because of the POCSO, which will come into play here. Yeah, thank you so much. So abortion is legal. Let us make it safe and respectful. So Samarth Safe Abortion made available respectfully throughout health system. It's wonderful program. I think I have changed when I see a young girl and a boy when they walk in for an MTP. Now I don't say that. Otherwise, earlier I used to be very judgmental and biased. I used to say why they did the mistake, why they did not understand. You know, all these things I used to think. But now after reading this, I never do that. Very respectfully, I see the patients and give their choices. Hello, Dr. Kiran. We were missing you.
Hello, ma'am.
Hello, Kiran ma'am.
You have made the topic so interesting and mesmerizing talk, ma'am. You have covered all the things. You have really done a wonderful job. And I agree with you that confidentiality should be maintained and dignity. Patient should be dealt with the dignity, and we should respect the patient choice, and we should support that patient, and we should provide them the contraception advices. Thank you, ma'am. You have done a wonderful job. Thank you.
Thank you. Thank you so much. Thank you, Kanchan, for inviting us. See, we came all the way from Hyderabad to आपके शहर में आ गए हम.
Come physically, ma'am.
और वो कौन थे जो सब्जी मंगा रहे थे खाना बनाने के लिए? वो
We will go there and have dinner. We will go there and have dinner. And there is one question in the chat box.
बोलिए.
Please clarify the role of medical board after 20 weeks.
But up to 20 to 24 weeks, there is no need of medical board. Only after 24 weeks, it is the medical board which comes into play. Now, because the new amendment has extended up to 24 weeks. But 20 to 24 weeks, you have two healthcare professionals to take care of the abortions. And after 24 weeks, only the medical board comes. In the old act, up to 20 to 24 weeks, the medical board used to come. But now it's not necessary. Now, 24 weeks onwards, the lady has, you have to send the case to the medical board. They will decide after going through all the papers and what is her pregnancy, what is the reason why she want to go for an abortion. And after that, they will give you permission or reject permission. And now when the boards are not formed, we have to go to the court and they form the temporary board and they will give the permission. Because some of the states still medical board has not formed yet.
There is one more question, ma'am. What if parents are not willing to abort in case of minor?
That is their choice. See, any rape survivor, so that will go into a POXO case. Most of the time minors means it is rape cases, but if they are married, if they file a case, then only they come to you. So if they come and continue it, but still, you know, you have to be very careful. Under 18, it is POXO. You have to know about.
Steeman, please take care of the extra noise, please.
Who written an open letter a few days ago, has also spoken about this.
Steeman?
Yes. If it is Sriman, please mute that person. Thank you. Thank you. So if it is minor under 18 years, then if they come for termination, then you have to inform the POXO. But if they are married, then they come for continuation. You have to be very careful about those things. You have to mention and you have to, because this is a social cultural problem in our country. Because they are married, they will, mother-in-law, mother, everybody agreeing to her to continue her pregnancy. I'm sure even now, a lot of girls are married at 17, 18 and they come for pregnancy. So we cannot say, but here we have to be very careful how to deal with them. But if anybody comes for MTP, you have to inform POXO. You have to inform POXO. There is no question. Even if they plead that please don't do it, socially it will be a badnaam, ye hoga, wo hoga. बहुत plead करते हैं. But I think you should not budge on that and you have to inform. Because you will be saving yourself.
Thank you. Thank you so much, ma'am. Thank you so much, Kiran ma'am, and thank you so much, Jamna ma'am, for this wonderful talk. And now we move on to next talk, for which I would like to invite the chairperson for the talk, Dr. Priyanka Garg, and she's so ever smiling and so active, and she's Secretary, Meru Tapsan Gynae Society. And I would request her to kindly introduce our speaker for the next talk.
Thank you, Dr. Kanchan. The webinar is so wonderful. We are totally engrossed into it. Jamna ma'am's talk was amazing, actually. And as we all know that respectful abortion cannot be completed without contraceptive advice. So abortion and contraception go together. So this last session would be even more enchanting as we learn about contraception from a very, very learned speaker, none other than Dr. M. Uma. Yeah. Hello.
Hi.
Yes, ma'am.
Hello, ma'am.
Hi, how are you?
Yeah, thank you. Thank you. Thank you, ma'am, for being with us today. So please kindly move forward with your lecture.
Can I share the slide?
Yeah, please, please, ma'am. Please, the stage is...
Can you see the slide?
Yeah, it's visible, ma'am. Perfectly visible.
Ma'am, Uma, your voice is a bit low.
Just make it full screen as well.
Yeah, 1 minute. Okay, am I audible?
Yeah, yes.
And it's visible, right, clearly?
has to be made full screen.
Yeah, it's made full screen.
No, it's not full screen on this.
I'm seeing it as full screen here. And it's shared. Is it visible now? Hello?
It's visible, ma'am, but it's not in slide share mode.
Oh,
make it full screen.
Mode.
Make it full screen. I mean,
it's full screen now. On my laptop, it's going
on
full
the
screen.
Actually, ma'am, it's not coming full screen. आप एक बार इसको just put escape and again do full slide share mode.
मैम एक काम करिए मैम, when you click the share screen button, no, just you select screen, not for the presentation. Only screen you select. After that, all the screens will be visible.
Pardon me. So I'll click share screen.
Share, then you
turn the
screen.
That's all.
Screen. Yeah, first one.
Yeah, I'm sharing.
Then you click the share screen button, and
then I am clicking slide share. Now it's on slide share mode. I mean the. Is it visible now? Slideshow.
No, ma'am.
Okay, I don't know. Maybe I should go ahead like that.
Here it's okay, ma'am. You can go ahead like this only. It's visible.
Yeah,
okay.
yeah. Okay, thank you. So yeah, after 1.5 hours of the program, it would be a tough task, I'm sure, to understand and learn about counseling aspects of pre and post abortion care. But I would want to highlight this is an important part of a family planning counseling. Now, in this module, we'll be discussing about pre and post abortion family planning counseling, how to use technology, how to adopt current and changing trends towards online consultation. Now, how do you define counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So this is the actual definition of counseling. And the important point to consider here is that the patient voluntarily seeking help, and so she is open for discussion and to share her thoughts and feelings. So you should also be
Ma'am, stop. Ma'am,
hello.
Ma'am, stop shares. This one, ma'am. The full screen visible. It is not here.
So someone can share the screen.
Yeah,
then?
yeah. It is fine. Now it is fine, ma'am. Now it is fine.
Pardon? It's fine now?
Yes, just your share screen once again, ma'am.
Can you share the screen for ma'am? If ma'am is having some technical issue.
I'm sharing it again. See?
Yeah, now it is perfect, ma'am. You can go ahead.
So I'll go ahead like this. Hello?
Yeah, it is perfect, ma'am. Now you can go.
Okay. So counseling is defined as a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Important point to consider here is that patient is voluntarily seeking help, and so there can be an open discussion, and obviously the patient will be open to discussion and share her thoughts and feelings. What is pre and post abortion counseling? We should note that pre and post abortion counseling is integral part of comprehensive abortion care services and is as important as providing abortion itself. This counseling should be focused towards helping women to take a decision about family planning methods. If needed, or not a must though, partners should be involved in counseling to maintain synergy and move on. Pre-procedural counseling should help women decide about termination of pregnancy, help women to choose method of termination of pregnancy. Once decided upon termination of pregnancy, you have to explain her about the options available for termination of pregnancy, medical, surgical, etc. Ensure delivery of complete information about the procedure she chooses to help women to adopt a contraceptive method at the end of termination of pregnancy. So the pre-pregnancy procedure or the abortion counseling is to ensure safety and privacy and confidentiality to the patient. We as doctors should be non-judgmental and be sensitive to patients' needs, concerns, and all this in a way to establish rapport and build confidence in patients. Don't use any medical jargon. Do your counseling in simple, plain language and give her time to allow women for any questions. Clarify her doubts in the form of open discussions. That is what we define as counseling. And lastly, once decided on termination of pregnancy and the method of termination of pregnancy, assess her for the procedure she chooses. Issues you need to discuss during peri-abortion period is about the other issue which you need to discuss is about the family planning method. You have to inform her that there will be quick return of fertility after termination of pregnancy. So you have to seek this pre-abortion or peri-abortion period as an opportune time for contraceptive acceptance. Suggest minimum of 6 months of gap before next pregnancy by counseling about health benefits and future pregnancy outcomes if there is a spacing between pregnancy. This is for us to note that 90% of abortion-related maternal mortality can be prevented by ensuring a safe contraceptive method, by using a safe contraceptive method. That is why it is so important to discuss about the family planning services during this peri-abortion period. During pre-abortion family planning counseling, you can start during her first consultation or first visit to your clinic, except when there is an amount of grief involved. If there is an amount of grief involved, you can delay discussing about family planning counseling to the next consultation. Counsel her about quick return of fertility after termination of pregnancy. It can be as early as 10 days to as late as, sometimes can be extended, but it can be as early as 10 days. Help her to choose the family planning method from the variety of family planning options available. And if she chooses, give her a method-specific counseling and also discuss about the high-risk behavior and the safety issues with her high-risk sexual behavior, if applicable. So what are the general guiding principles, rules to for suitability of post-abortion contraception? Check abortion process is complete. There is no evidence of sepsis or no evidence of retained products of conception. No injury to the genital tract. Fresh pregnancy ruled out in case there is delay from termination of pregnancy. And you have to ensure that she is accepting this procedure very well rather than we forcing some kind of contraceptive method on her. Coming to post-procedure counseling, during post-procedure counseling, during this period, we should ensure that woman has understood the precautions and care needed during this period. Take opportunity to counsel again for contraception if it has not been decided already or not been accepted earlier during pre-pregnancy counseling period. And reinforce the need for continuing the use of contraceptive method or she chooses if she has already chosen. So during post-abortion counseling, it's the same procedure. Continue to ensure privacy, confidentiality, reassure her in case of any problems or any issues she wants to discuss about contraception. Repeat the information about post-abortion care and danger signs, or when she has to report back if in trouble. Coming to post-abortion family planning counseling, if she had already opted or chose a method, you should appreciate her first. Depending upon the method chosen, you can be some methods can be given immediately, say like IUCD or DMPA. Follow protocol for each method has to be explained to her, and there should be continuity of care, and you should also discuss with her about the future reproductive plans as to for how long she should continue this contraception, considering her future reproductive plans. Provide her with any cue cards or any patient information leaflets available online, or you can prepare on your own for your clinical practice. If she is undecided about the contraceptive method she chose, method she wants, or a decision has to be made about the use of contraception, allay her anxiety and discuss any information, from any sources, websites, cue cards again to decrease her anxiety, ensure safety, discuss importance of immediate adoption of contraception. If still resistant, schedule another visit over an extended period of time. When there is a need, involve couple during counseling. Discuss about emergency contraceptive pills. If after all these efforts of yours have failed, at least discuss about the emergency contraceptive pills available. Now, post-abortion contraceptive methods. So we'll be discussing about the various methods which we can offer, and from what time she should use which method, after first trimester abortion and after second trimester abortion, how long should she wait before she starts on those emergency methods she chose. So we will just briefly go through the various methods currently available and when she can start after first and second trimester abortions. Or any additional information you need to provide, and when she has to report back has to be highlighted to the patient. First, talking about the barrier methods, condoms are the commonly used barrier method of contraception. After first trimester abortion or even after second trimester abortion, it can be used as soon as sexual activity is resumed. And additional information you need to provide is that they are safe, no hormonal side effects, can be used without consulting a healthcare provider, easily available, and an additional benefit of prevention against sexually transmitted infections, including HIV. The next method we will discuss is about the intrauterine contraceptive device. Any device, let it be for 5 years or 3 years, intrauterine contraceptive device can be inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method. With medical abortion, it can be inserted around day 15 of the process, provided you are sure that there are no retained products of conception or is no risk of any infection. If there is any infection, it's contraindicated. Post second trimester miscarriage, it can be inserted immediately or up to 12 days after the procedure is complete, and any contraindications like again infection or retained products of conception are ruled out. Additional information you need to provide with regard to IUCDR, that obviously for all contraceptive methods, you need to talk about the efficacy and effectiveness. And additional information is, for how long she has to use this IUCD, depending upon the variety of IUCD you have inserted. It can be provided by trained doctor, MBBS or ANM nurses after first trimester surgical abortions, but after second trimester, it can be only by a doctor. It doesn't interfere in sexual activity and immediate return of fertility upon removal of IUCD. And again, the major advantage is that it doesn't have any hormonal side effects. Next method we will discuss is about the combined oral contraceptive pills. So combined oral contraceptive pills, we can start immediately or up to 7 days after abortion using surgical method. With medical method, it can be started on day 3 with the use of misoprostol or within day 15 of the process after confirmation of complete abortion. Post second trimester termination of pregnancy can be started immediately or up to 7 days after abortion. Additional information is that it gives an advantage of regulating your menstrual cycles, no interference with sexual activity, offers protection about ectopic pregnancy, endometrial and ovarian cancer, and benign diseases of breast. But again, estrogen contained contraceptive pills are not suitable for women who are breastfeeding babies who are less than 6 months old. Obviously, it's shown that there are some amount of hormone in the breast milk. So, if there is a woman who is breastfeeding, don't prescribe combined oral contraceptive pills. Then the best drug of choice is the progesterone only pills. The next hormonal contraceptive method is the long-term injectables, medroxyprogesterone acetate or DMPA. It can be, injected immediately or up to 7 days after surgical method post first trimester termination of pregnancy. With medical method, it can be started on day 3 along with the dose of misoprostol. After second trimester termination of pregnancy, it can be given immediately or up to 7 days after abortion. It's very effective, no interference with sexual activity, no effect on quality and quantity of breast milk, no estrogenic side effects, offers protection against ectopic pregnancy, CA ovary, but main drawback is that the return of fertility takes sometimes up to few months post after stopping the contraceptive method. So what are the other permanent methods of permanent methods of sterilization? Permanent methods are female sterilization, tubectomy or vasectomy. Female sterilization can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days both by laparoscopic sterilization or mini laparotomy, whatever she chooses. With medical management, it can be done only after the first menstrual cycle. After second trimester termination of pregnancy, mini-lap sterilization can be performed concurrently or up to 7 days after the abortion. In the absence of any infection or severe blood loss, laparoscopic sterilization is not recommended if there is severe blood loss or any infection. Only thing, patients should be knowing that it is a permanent method of sterilization. It's a permanent method with highly effective immediately, and no interference with either breastfeeding or sexual activity, and obviously no long-term side effects. Vasectomy, performed on males independent of the timing, no relation to procedure of the abortion. Again, the same. Very effective, very permanent method of contraception, no interference with sexual activity, no long-term health risk. But the only thing is the couple should be explained that they should use another method of contraception for at least 3 months post vasectomy. So this is just a slide to show, when to start which kind of contraceptive method and, how we can use, till when we can use. So now coming to, this brings us to the future of SRH services, the teleconsultation and use of other technologies for the sexual and reproductive health services. I think COVID has taught us all, like how we are doing this meeting or Zoom, that there are certain services like teleconsultation, we were using telecounseling, teleguidance or telereference or telelinkage, or give you websites, go through the websites, book appointments with the doctors or whatever. So even patients learned it and we learned how to use it. So now everybody is well versed with websites, get information from internet, more than us, patients will be getting more information through various websites, through their friends. Lots of helplines are available to provide information. There are more public information leaflets on the website, on the various platforms like the WHO, RCOG, ACOG, or the Ministry of Health. So patients know how to utilize technology to adopt to healthcare, and we started using it. So how can we implement these technological services into the sexual and reproductive health services? Why can't we use it? Yes, we can use it, but there are certain strengths and weaknesses. The main strength is that it is approachable throughout, and this process is very simple, and patients are confident of using this. It is, most of the time patients wouldn't have thought of consulting a doctor who is far from their place or whatever. So without thinking much about the logistics, patients became confident and started using the technology. And it has even the remote of the population are now aware of this. The main weakness is that, you know, we lack the face-to-face counseling, or as we are desperate for face-to-face physical conferences. So the face-to-face interaction, or how we observe certain patients on face is lacking. And obviously you can't demonstrate if you have to demonstrate certain things, like say like use of sexual female condoms, or you want to explain the use of pills, or graphically, or whatever. If you want to demonstrate few things, that might not be possible on the teleconsultation services. But again, it's an opportunity where patient can speak from her home. There is a lot of privacy and comfort of home. And obviously the logistics, the travel costs, etc., all come down. And also the number of visits are definitely less. The main threat is that there can be a missed opportunity or misdiagnosis. Without seeing the patient directly, we might miss upon the diagnosis of few things, or miss some medical disorders, which few complicating disease problems within her. So, so there are plus and minus, but then how can we apply of these teleconsultation services for abortion care services and sexual and reproductive health services? So they can be a kind of a hybrid mode of providing the care. Initial assessment, confirming the diagnosis, confirming by scan, can be by a physical visit. And during that initial visit, you can discuss about the future contraceptive options. Then later counseling can be, any further counseling about contraception, or further discussions can be by a video conferences or Zoom or whatever. So kind of can be made as a hybrid service. Maybe number, even for medical method, the number of visits can be cut short to just 2 visits, and later on, depending upon the need, we can always call her. So the key message here is that we need to realize that there is a post-abortion family planning services. Family planning counseling is extremely important, and we should realize that that it's extremely important, and we should work hard to bring the couple on board and strive for near 100% coverage whenever possible. We should capitalize on the basket of contraceptive methods available and its applicability in post-abortion or peri-abortion period. As far as possible, use technology for comprehensive abortion care services. It not only reduces the cost, increases patients' privacy and confidentiality, and so our work towards respectful abortion care services might be fruitful, and also improves access. Now, there are certain concerns about policies of teleconsultations, the malpractices. The onus is on doctors on how we take this as a what do you say, to avoid as a practice, to avoid any legal issues and malpractices. It has to be within ourselves to do it in an ethical and legal way. And of course, adolescent reproductive health also can be done online, but at least again, hybrid methods are the chosen option. Thank you. And of course, you need to do the post-test questionnaire and submit the feedback to get your certificate. Thank you.
Yeah, it was an amazing presentation covering each and every aspect of contraception. Dr. Kanchan, are you here?
Yes, Dr. Priyanka. And there is one question, I think the answer has already been answered. Is there any upper limit of abortion for congenital birth defect?
No, not really. There is no upper limit. But only thing is, after 24 weeks, you have to refer the patient to a nearest medical board and the medical board will decide upon the termination of pregnancy, and then only after seeking permission from medical board you can terminate the pregnancy.
Yes, definitely. But there's a problem. There are no medical boards in some
Yeah,
states, which
there are
Madam
no
has
medical
already
boards.
discussed. Because in Uttar Pradesh also very less medical boards exist as of now.
Same in our place. We are fighting. We are talking with the government. See, medical board
Yes.
formation is a state subject. Passing law is
Yes.
a central subject. The formation of medical boards is a state subject. Now it's
Yes.
individual state responsibility to form medical boards. There are, even in our state, in Andhra, medical boards are not yet formed, and there are a lot of limitations.
Yeah,
about
that is why always the responsibility lies on the gynecologist and obstetrician only,
so
actually.
we have to be legally right, we have to follow that, and otherwise they have to go to court. That's the option available. That's all.
Thank you so much, Uma ma'am, and thank you, Dr. Priyanka Gar, for this wonderful session. And there is one link posted in the chat box for post test to all the delegates, and they have to submit it. After only that, they will get the certificate. So I request all the delegates to kindly go through this link and submit their post test questionnaire. So this comes to an end to this wonderful session, and it's so I'm so happy to see so many delegates still online, still they are joining us. So and now meanwhile everyone is filling this post test form, I would take this opportunity to thank everyone. And first of all, I would like to thank our President Santa Kumari Madam, who has in collaboration with WHO has initiated this wonderful program, and that too online. So people don't have to go anywhere. They can sit comfortably at their home, and they can learn what is new in MTP Amendment Act from their home only. So I want to congratulate and thank our President. And I want to thank our chief guest of today's program, Padam Shri Professor Dr. Usha Sharma ma'am. She is always so warm, so active, and she always supports us. So I want to thank ma'am for the blessings. I thank our guest of honor, Dr. Archana Verma ma'am, for all her encouragement. She's a lovely, vibrant person. I want to thank Bharti Maheshwari ma'am. She took all the pain to coordinate this webinar. So I really want to thank ma'am. She has done so much work in this MTP when she was MTP committee chair. And I want to thank the other convener, Dr. Richa Sharma ma'am. Again, she is doing wonderful job. I want to thank all the esteemed speakers, Dr. Krishna Kumari ma'am, Dr. Shaili Agarwal ma'am, Dr. Jamuna Devi ma'am, and Dr. M. Uma, and all the chairpersons, Dr. Pragati Agarwal ma'am, Dr. Alka Sethi ma'am, Dr. Kiran Chandana ma'am, and Dr. Priyanka Gar for giving their valuable inputs. And at the same time, I also want to thank all the secretaries and president of all the society who have logged in and who have joined our hands. The Merit Society, Muzaffarnagar, Muradabad, Bareilly, Noida, Jhansi, Faridabad, Ludhiana. So total 8 societies have enrolled for today's webinar. So I really want to thank them. And I want to thank all the delegates who are listening patiently till this time. And I want to thank Ajay sir, Ajay Bhardwaj sir, for giving all the support and all the help whenever I needed. So with this, I end my vote of thanks, and I'm waiting for all the all the delegates to complete the questionnaire, which is essential to get the certificate.
Where we can get the link?
It's in the chat box.
It's not showing.
Ma'am, it's there in chat box. Go up.
Okay, got it. Thank you.
Where is it? In the beginning of the chat box, Dr. Kanchan?
Yeah, got it. Thank you.
No, I was also searching yesterday.
It's not beginning. It's after. Just go up. It's coming just before 3-4 comments.
Can you repost it once ना? अभी आ जाएगा. Okay.
रिपोस्ट कर दिया
Yeah,
मैंने.
it's there.